it through a small incision. And talking about the minimally invasive, I like to quote some papers that this is from the Italian group. There's about 1,600 of cases and 70% of the repair, 29% of the replacement. And the conversion rate is 2.5%, 10-year survival of 88%. Freedom from reoperation for the repair is 94%. Freedom from the recurrent mitral regurgitation is about 90%, which is quite similar to what you do in the conventional way. And looking in this paper with the repair group, and about 1137 of the repair got a good result with low operative mortality, low stroke, and or the other comorbidities. So, and this is another paper from the expert like Posterior group. He did all of the mitral valve repair. He do 842 cases in 6-year review. Mitral repair rate is 99.3%, almost all. Operative mortality is quite low, 0.2%. MACC is only 7.2%. He got only re-repair in only 2 cases. So in experienced hand, this is very good. However, look into the detail, he still have some complication related to the minimally invasive procedures like conversion, some bleeding, some retrograde aortic dissecting, but that in very small number. And once get familiar with the technique, this complication rate is not different from what you do with the conventional way. This is another paper from Japan. This is doing the totally endoscopic way with this very small incision and not looking into the wound, just no direct vision, only using the endoscope, and got a good result too, with a 5-year survival of 98%. The operation free rate is 96.9% over 5 years. So this is quite good. He did 233 repair. So what I mean is that in experienced hand and of the minimally invasive setup and the repair technique, the minimally invasive mitral repair can achieve a very good result. And this is our setup. So we do the same thing as the others. And I'm sorry that this is not can be well visualized. So we focus on running the cardiopulmonary bypass, make sure they got adequate venous drainage. And we usually prepare right interjugular vein first in here, right interjugular vein, and we did a double lumen intubation. When we enter the chest, we will collapse one lung just on the right, that may have more space, and if it need to, for adequate venous drainage, we can put another cannula in the right interjugular vein. And this is quite important when you do the minimally invasive. And we try many techniques. And this is the right hand port. First we use a 3-port, like camera port, right hand port and left hand port. And then put another left atrial retractor hole in the top of the wound. And one for the left atrial retractor and one for the cardioplegia. And if you expertise in using the camera, just like when you put the camera into the lower part in the C spot here, then you can see like the baseball field, just like this. So you can see all of the exposure of the mitral valve, and then you can do the repair exactly the same what you want to do with the conventional way. So this is quite our setup, but lately it depends on the case too. Sometimes we didn't put too much port, sometimes 2 ports, sometimes only one port for the camera and put all the instrument and the into the incisional wound. It's about 4 to 6 centimeters. And in our practice, only in selective case that we do the totally endoscopic, but in most of the cases we do combination of the direct vision and the using the endoscope to help when we do the repair of the mitral valve. This is the cannulation. So to achieve the good venous drainage, so we put this inside. This is the surgeon will put it in by themselves using the fluoroscopy or using the echocardiogram guided to make sure that you got a cannula safely into the system, femoral and additional venous drainage from the right internal jugular vein, and it does help. For the port placement, as I told you, we use many techniques, but in most of the case, we have only one port put in just for the camera, and all the instrument put into the incisional wound, and it would help minimize the complication of the chest wall bleeding. And when we enter the right force in the causal space, which is directly into the important landmark. Like first is we have to identify the left atrial, the interatrial group. This is pulmonic vein, interatrial group here, and to get into the left atriotomy and get a good exposure of the mitral valve. Second is that where we put the clamp, we normally put it to the transverse sinus. There is space there, and the cardioplegic spot is just right a bit on the lateral side, on the surgeon side, the medial side. This is what safer. If there's a bleeding later, we can control it. So we try many spots, and we select the spot that is comfortable for us to get a safety for the patient. And for the incision, we try many. We start from a bit more anterior. We move to a bit lateral. Then we move back to just in between this incision here, about 4 centimeters, close to the nipple. And in some cases, we do with periareola too, with the 3D endoscopic, but that in very selective case. And this is what we see inside. This is an anterior mitral leaflet repair. Pathology is the rupture of the anterior cord. We use the neocaudal placement, and we use the retraction stitch of the cordy to expose all the anatomical landmark that we need to put the suture in and the stitch. And then we do everything as the same, similar with the conventional way. This is another case of posterior mitral valve leaflet repair. So the pathology is this P2 prolapse with the ruptured cord as well. We usually put the annular stitch first, and then try to do the good exposure of the papillary muscle and the pathological leaflet. And we do just the same thing as we do in the conventional approach. And this is just like the same. And closure of the cleft of P1 and P2 to secure make sure there's no regurgitation at all. We're really familiar with this technique and got a good result. This is another case of posterior mitral valve leaflet repair too. Do the same thing. You see that the black silk there, that is we encircle the cord and the leaflet and push it away. So in this case, we can expose to the papillary muscle, see the cordy quite and the leaflet quite clearly, in a good visualization, and we got a good result with this kind of techniques too. Sometimes we have to retract the leaflet with some kind of 4-O-proline and retract it to the left atrial wall temporarily when we finish with the repair, and we just cut the stitch off. And this is help with the minimal invasive technique in our experience. Another case with multiple rupture cord on the P2, we do the same things. We utilize many techniques. In this case, when we adjust the chordy using the clip and to estimate the proper length. In this case, we put like 3 cords, one lateral and one in the middle, and this achieve a good result too. So the technique is vary in between cases, but the principle is the same. Retraction, the leaflet annulus to get a good exposure to be able to do the valve repair. And we invite Patrick Pereira to teach us how to do the 3D endoscopic. This very small incision and nearly periareola, and then this is what you see inside, opening the pericardium. This is totally endoscopic, like the with no direct vision. So the same thing, identify the atrial group and cardioplegia, identify the place for the putting the aortic cross cam on. And his technique is he used a lot of the retraction suture to help to expose the where you are going to put the suture in. And he put the annular stitch last, so this depends on the case too. If the exposure is not good, we normally put the annular stitch to help as well. But you have to be careful that it not tangle with the annular sutures. Got a good result too. And in 17% of our case, we do the concomitant tricuspid valve repair as well, and the video did not work. So just the same thing, some retraction suture to help, and then we can do the tricuspid valve repair concomitantly with the mitral valve repair. And the same as we got the 31% of mace, we do it the biatrial mace, modified Koch mace 4. We do the right side lesion first on a beating heart. Our technique is we use mostly of the bipolar, and on the isthmus side, we use the cryoprobe. We do the right side lesion completely first, and then open the left atrium and do the left side mace as usual when we do with the conventional technique. Just only the far part of the left pulmonic vein line, we use a cryo. That's the different. And in our experience, we compare our 261 cases of mini mitral and full, and 261 of full stenotomy. And what we found that we got less blood transfusion, less bleeding with this minimally invasive technique. So otherwise, it's quite the same. In this group, we have 17% of tricuspid valve repair, 31% of MACE, and 0.8% operative mortality. Conversion rate is 2.4%, 4.6% of MACCE, and 0.8% of preoperative mitral surgery at follow-up of 6 years. We got some complication here related to the minimally invasive techniques, but it's very small number. So when we got more experience, this can be minimized. This is a postoperative blood loss and transfusion compared between our series, our two groups. And in this mitral surgery of over 12 years, this is my personal experience. I have done 602 cases. 43% is a minimal invasive. And in the minimal invasive group of 261 cases, 67% is a repair. And in the repair group of 176 cases, the isolated mitral repair of 87% and concomitant of 13%. And in the concomitant group of the 13%, the 6% of MACE, 5% of tricuspid valve repair, and 3% of closure of the ASD. By the etiology of this group, mainly is the degenerative and chronic IE, about more than 90%. 2% of the rheumatic and 2% of the congenital. Related to the leaflet pathology, the majority is the posterior mitral leaflet in 38%, anterior mitral valve leaflet is 22%, bileaflet prolapse in 24%, commissural prolapse is about 16%. And the technique, 76% using the neocord. In the small number, we use the loops too in the first start, but when we get familiar with the exposure and everything, we found it much more easier and comfortable to use the neocord placement with the similar technique that we use with the conventional approach. And mainly use the complete ring, mainly is the Physio2. And this is the number. The age, average age is 58 years, and atrial fibrillation of 5.7%. And conversion, no conversion to sternotomy in this mitral valve repair group. This one operative death, 0.6%. New atrial fibrillation in 1.7%. Or early events of the complication is 7.4%. We follow up to the mean of 6 years, and no late death, no bleeding event. Thromboembolic event is about 0.6%. Pacemaker, about 2.3%. And the recurrent MR is for needing preoperative mitral surgery in one case. That case got the infective endocarditis, and in that case we did repair, but by conventional approach by sternotomy. All late event is about 2.8%. And this is a survival probability and freedom from MACCE. This is quite satisfactory. And Mr. Chairman, in summary, we think that the minimally invasive approach for surgical repair of mitral valve disease is possible, rapidly evolving, and has progressed safely, eliminate the need for full sternotomy approach in experienced team. Excellent result can be achieved through this smaller incision by expertising using the endoscopic camera, new developed instrument that would help, and cardiac surgeon really need to have special expertise in the minimally invasive setup and the repairing techniques of different approaches tailor-made for each individual mitral valve surgery patient. And in our experience of 176 cases over nearly 10 years, this have shown better cosmetic satisfaction, less bleeding, less blood transfusion requirement, similar effective hemodynamic performance, and comparable early and late clinical result to conventional approach. Thank you very much.
Thank you very much. And his result is excellent. I'm very impressed. But the mean age of the patient, I'd like to make sure mean age in 58 years old.
Yes.
And the concomitant procedure for HFib or concomitant procedure for tricuspid is not so large number. So in Thailand, cardiologists push the patient early stage of repair is recommended, or mainly United States, in Japan, even in Japan, so the mean age almost early 60s or something. And in my experience, 30% or at most 50% of the patient required concomitant tricuspid, or 30% required MACE procedure, a little bit high incidence. Let us know the reason why the concomitant procedure is so low number, low incidence.
Thank you very much. We have the similar number in the whole group of mitral surgery. We have more of the like 31% of MACE, but mainly and 70% of the repair of the tricuspid concomitant, but that in the mitral valve replacement, which mainly is the rheumatic. But in the repair group, mainly in our series is the degenerative, and as the cardiologists just already know that push it a bit early too.
So this is
in our series very small number, as you mentioned, of the MACE and the concomitant tricuspid repair in the repair group.
Yeah, thank you so much. Is there a comment on the question? It's a very excellent result, I guess. Yes, Shibata.
Good morning, my name is Shibata from Osaka. Thank you very much for a nice result. And your result is very nice. And as Dr. Okada said, your patient age, mean age of 58. How do you do if the patient age is 75 and simple P2 or P3 prolapse? And can you do that as a minimally invasive? Or the minimally invasive has a good for patient. So my opinion, we adapt to the elderly patient if the no anatomical problem. How do you think about that?
I absolutely agree. We do the same thing. The age is not the contraindication, but in our series, the mean age is about that. But we have some people in the small number that over 75 years old.
Thank you.
We don't think that the age is a contraindication if the anatomy allow.
Is there any comment? Okay, thanks so much.
Thank you very much.
Excellent. Second presentation is my presentation concerning the what? Tawisa asked me to talk about the tricuspid valve repair, and the topic, the title, how I do it, and choice of valve ring. And as you know, traditionally, Alain Carpentier developed a new concept and reported the so-called how to repair the tricuspid using a prosthetic ring in 1971 and 1910-year appraisal, 1980, and then they summarized French correction in 1983. The basic concept to treat the functional tricuspid gauge doesn't change for more than 30 years. By the way, guideline. This is the guideline 2006 Class 1, Class 2. Every guideline, every stage, the tricuspid intervention was limited to severe tricuspid gurge. Of course, Class 1. And the Class 2A, even in Class 2A, severe primary tricuspid gurge when symptomatic or severe tricuspid gurge. This is the guideline 2006. Then 2008, tricuspid surge according to, and this is the guideline, Class 1, severe tricuspid gurge, and Class 2A, so mild tricuspid gurge when there's a pulmonary hypertension or tricuspid annulus dilatation. How much? There's no description, okay? So this is almost 6 years ago. Guideline, new guideline, 2014. Class 1, severe, of course, and Class 2A, regardless of grade of tricuspid regurgitation, tricuspid annular dilatation, or prior evidence right heart failure level evidence B, the 2A recommendation. And so anyway, last 20 years, the guideline, which condition should we intervene, so-called tricuspid surgery, changed. So this is these 5 retrospective observational study from Kobe, find out several risk factors developing recurrent tricuspid gurge or something. And you can see several figures, and tricuspid gurge increased, and tricuspid gurge just after surgery has a negative impact on survival and event-free survival. So, 2007, I totally changed my criteria to repair the tricuspid. At first, the tricuspid regurgitation by echo, moderate or more, including moderate. History of right heart failure. It's very easy to control right side symptom with diuretic something. So it's very important to take a history of right heart failure. And HFib, we have now made procedure, but 20 years ago we didn't. So the HFib developed the tricuspid gurge after surgery. And pulmonary hypertension. The mitral patient with the degenerative mitral gurge with pulmonary hypertension, 50 millimeter of mercury or more, some patient, maybe around 12 or 15% of the patient still persist pulmonary hypertension after repair. And then after, recently, tricuspid annular dilatation, 21 millimeter per square meter, But who measure the tricuspid annulus? Where? Tricuspid annulus is so funny configuration. It is not easy to measure the correct diameter, as you know. So the 10 years before data, 15 years data is not applicable. So this is the tricuspid annuloplasty using a triad ring for patient with the tricuspid annular dilatation without pulmonary hypertension and without HFib and not so severe tricuspid. But even for these kind of patients, I tried the tricuspid annuloplasty because tricuspid annuloplasty takes only 15 minutes without trouble. So I always make a stitch under cardiac arrest. The ring size, in my case, the patient body surface area is not so large in Japan, in Japanese patients. So usually for men, maybe 28, and for small lady 26. And since 2007, I moved to 7 years ago. I moved to public hospital to private one. So this is the data since 2007, and 283 patients. The mean age 61, and associated with the tricuspid annuloplasty, 55%, and mitral valve repair without tricuspid, 45%, and the residual tricuspid gurge at discharge, you can see 80% trace or no, and mild 20%. There's no significant difference between the patient with tricuspid annuloplasty or patient without tricuspid annuloplasty. You can see the 5 years after tricuspid annuloplasty, there's no tricuspid gurge, mean gradient across the tricuspid valve and 2 millimeter of mercury. Right ventricular ejection fraction, 41%, almost normal. So the event-free and survival is quite similar to the patient without tricuspid annuloplasty. So Mays procedure, aggressive tricuspid annuloplasty improved the event-free survival after mitral valve replacement, mitral valve repair for mitral regurg. Then, severe functional tricuspid regurg, extreme huge tricuspid annulus, and tethering. What should I do? This kind of patient, has a risk to persist the residual tricuspid regurg. So at first, I did leaflet augmentation as described. I was reported geodurfis. It's very nice procedure. And I reported the case report in 2013. But this technique is very, very time consuming. So I started the Clover technique and by Alfieri, Dubonis, and after ring annuloplasty, and make a stitch between the anterior, septal, posterior center of the leaflet. It's very simple. At first time, I was very afraid of mitral tricuspid stenosis after making a stitch, and during the operation, I asked my anesthesiologist to analyze the tricuspid flow very frequently. but there's no significant tricuspid regurg and also tricuspid stenosis. So this is the 93-year-old male suffering severe tricuspid regurg, and 5 years after Clover technique. And you can see no regurg and mean gradient across tricuspid valve, 3 millimeter of mercury, but ejection fraction is not so good, 30%. Right ventricular dysfunction, systolic dysfunction persists after tricuspid surgery. Another one, you can see several cases you have lead-induced severe TR. This is a patient, 75 years old. After mechanical mitral valve replacement, CRT was induced to improve ejection fraction, and right ventricular pacemaker lead induced severe tricuspid regurg. So there's a huge dehiscence of the posterior and septal leaflet, and dissected and reattached just outside of the annulus, and make ring annuloplasty. Now the anastomosis between the posterior leaflet and septal one, and rigid ring was implanted. You can see here right ventricular lead, pacing lead outside the prosthetic ring, and also a Clover stitch. He had a severe right heart failure sign, leg edema, liver dysfunction, something. Functional class 4 before surgery. So this is the 4 years after Clover technique. No trace mild regurg, and across the tricuspid, repair tricuspid, mean gradient was 4 millimeter of mercury. But you can see right side ejection fraction of right ventricle was 25%. And diastolic volume, systolic volume, and persist the enlargement. So I think using this new technique, the right ventricular systolic dysfunction persists even after right tricuspid annuloplasty. So we used to analyze the so-called tricuspid regurg by echo only, and right-sided pressure, pulmonary hypertension, yes or no, tricuspid regurg, yes or no, that's it. But we didn't analyze, the right ventricular systolic dysfunction. So we have now 18 cases who underwent Clover technique. You can see a right ventricular pressure, almost 50, annulus dilatation more than 40, and tenting distance, mean distance 7, and concomitant procedure is always almost cases. And the hospital mortality is 5.6%. And the result functional regurg at discharge almost less than mild. And also, the tricuspid diastolic mean gradient was 2.0. So this technique is very, very reliable to preserve tricuspid function without regurgitation. So, in summary, aggressive tricuspid embolism for patient requiring mitral repair for mitral regurgitation improves event-free survival after surgery. In the patient requiring tricuspid surgery for severe tricuspid regurgitation, Clover technique is simple and effective to minimize the residual tricuspid regurgitation without stenosis. And last, right ventricular systolic dysfunction should be carefully followed up in the patient who had severe tricuspid regurgitation preoperatively. You know, the just guideline documented, we have to intervene, we have to treat tricuspid regurgitation before right ventricular dysfunction. What is right ventricular dysfunction before surgery? What is the parameter? What is the symptom? We don't know. So it's very important to follow or analyze right ventricular dysfunction before and after tricuspid intervention. Thank you very much for your attention.
Professor, can I ask you a question? I am Dr.
Yeah.
Vivek Zavli from India. This was very nice and elegant. The Clover technique, can you tell us some tips of your technique? Which is the suture material you use? And do you use any plagette or not? And do you run once or twice?
And at first case, the septal leaflet, the center of septal leaflet was very, very fragile. So that I make a stitch using a 5-0 monofilament suture, teared. So at that time, you know, the septal leaflet, center of stitch at this septal leaflet, make a small homologous pericardial plagette only, and make a stitch anterior, center of anterior leaflet, and then the posterior leaflet, and make a running stitch almost twice.
Thank you, sir.
Dr. Okada, always your presentation is very beautiful and very logical. And I have one question: is the right ventricular dysfunction is a very interesting and important matter. So, do you have any data comparing the preoperative right ventricular chamber size regarding postoperative recovering of the function? So I think there must be some kind of point the reverse recovery happens or not. So if you have any kind of suggestion.
At first step, I'm now just almost 3 months ago, we obtained a new echo analyzer. So we are now collecting the right ventricular ejection fraction after surgery. It's very important to collect the post-operative data and then come back the right ventricular function before operation. But the application is quite different. So-called we didn't have 10 years before, so we have to schedule how to analyze the so-called what is the so-called right ventricular dysfunction before. It's very important, as you noted. So this is our job in the future, I guess.
Okay, thank you very much. I'm looking forward to hearing your new data in the future.
Yeah, please.
In the early 80s, when I started ring annuloplasty for tricuspid repair, I had a couple patients with very delicate annuli where the rings dehisced. So I began using horizontal mattress sutures with superannular plagettes. And I've got a video on CTSnet of that. And And that worked very well over the years. Essentially had, well, I've had no dehiscence, but I've had no pacemaker requirement either. Now, the surprising thing to me was when we looked at this subject in the STS data bank with a large number of patients, the pacemaker rate in the United States is 14%.
14?
14.
Where do you make a stitch?
I don't know. I think that, I don't know. And of course, the dominant technique is this deep annular Carpente stitch. And I wonder if it's related to that. How much pacemaker problems have you had?
No, none.
None, okay. So it must be that they're putting them too close to the conduction system. But that's an interesting thing, and there was an interaction between a patient having a maze and a tricuspid repair, which was what produced the 14%. So, but it looked like it wasn't just the maze, that the tricuspid repair was a big part of it.
Yeah, but I'm afraid, I guess, by putting the maze procedure, so the right auricle, right atrium auricle to the tricuspid annulus, so close to the bone block, I guess, or not. I don't know exactly, but I can't believe it. 14% of patients require pacemaker.
We published that, yeah.
Oh, really?
Yeah.
Sorry, I didn't know.
Yeah, it's interesting.
Yes.
I would agree with the pacemaker discussion that I don't fully understand how we get 14%. But I have a question about right ventricular dysfunction. We have actually been looking at right ventricular function after heart surgery in general. And every patient that we operate on has right ventricular dysfunction early after surgery, and you can speculate in reasons for that. One could be cardioplegia, voice of cardioplegia, cardioplegia delivery. And so you can elaborate a little bit on that. And I do think that we need to follow right ventricular function from the time preoperatively, immediately after surgery, and to try to figure out what the reasons for the right ventricular dysfunction is. It may, so to say, have other reasons than that we operate too late. The second question is related to your choice of ring. Do you always use a rigid ring, or do you sometimes use a soft band?
At first, second question, I have used a flexible ring for more than 15 years because of the tricuspid annulus change its shape and size during the cardiac cycle, as well as in mitral. So I am a flexible person. I select a Taylor band, a Dram band, something. But after that, the huge right ventricular dysfunction, there's advantage to close the anterior posterior distance. So now I select the triad and partially flexible, and there's a very huge tricuspid annulus. We can't image the tricuspid annulus motion during the classical cycle. It's very easy to put on the so-called semi-rigid ring, I guess. But do you know how do we assess the so-called right ventricular function is the future problem, I guess. Nobody knows. There's only a guideline, just treat tricuspid before right ventricular dysfunction. But we don't know what right ventricular dysfunction is what. Symptoms or systolic function. It's just systolic function, just assessed by MRI or something. But the echo is very, very useful to monitor every time we want. So the data I showed today is the post-op data is 5 years after surgery, just after tricuspid angioplasty, at discharge, right ventricular ejection fraction much worse, small, less than 20%, and improved gradually. So it's very important to assess and what happened in the right ventricular function, I guess. Am I right?
Just one quick comment about the rigid versus band. In our experience, the rigid ring was significantly better than the band in controlling the tricuspid regurgitation.
Yeah, thanks so much. Any comment? So shall we move to this third one? So, third topic is the minimally invasive rheumatic valve repair. Somchai?
Yep. Thank you, Professor. My topic is the MAS rheumatic valve repair. I have no disclosure. I would like to begin with the case first. This is a male patient, 18 years old. 15 years ago, when he was 13 years old, he has the acute rheumatic fever with carditis. He was followed up with penicillin prophylaxis. Now he developed a Disney orange lesion, functional class 2 intratum. The chest layer showed not too big heart. Echo, this is the echo. Some polyp. Show severe metal regurgitation. I have two questions for the floor. The first question, what is the appropriate treatment for this patient? Yes, A, continue medical treatment, B, change the valve, or C, fix the valve. Who in this room you would like to continue medical treatment for this patient? Please show your hand. No. Who would like to change this valve? And who would like to fix this valve? Yes. Okay. And the question number 2 is, this is a guideline from the 2017 recommendation. Metal valve repair should be preferred technique when the design is to be durable. And now is the second question. What is the appropriate surgical approach for this patient? A standard sternotomy or minimally approach? Who would like to use the standard approach? Please show your hand. Who would like to use the minimally approach? Okay. In my opinion, I think this patient has the simple lesion. We can use the simple repair, and he is only 18 years old. I think if we can do, we should avoid the sternotomy. It's a sternum sparing approach because he is really young and he may have the chance to have the reoperation or the other sternotomy. So I choose the video assisted live minute-thoracotomy for this patient. This is just the video in this patient. You can see the lesion is allowed P3 lesion. There is some cleft and rupture cord here. Yes, allow the P2 and P3 lesion. So at first, I have to collect the lesion here. First I close the cleft between P2 P3. So I think this is a simple reason. We can do the simple repair for this patient. Close. Can we move ให้เร็วขึ้นไหมน้องๆให้เร็วถ่ายนิดนึงขยับ Then we do another plication stitch. So in this patient, I think we don't need artificial cord. Just close the cleft and plication and put in the ring. น้ำบูให้เร็วขึ้นนิดนึงขยับให้เร็วขึ้นขยับให้เร็วเอาไปตอนใกล้ๆจบไปขยับให้ใกล้ๆจบ Yes, and total test, and some more plication stitch. Yes, ขยับเลื่อนให้เป็นเร็วใกล้ๆจบใกล้ๆจบเลื่อนให้เป็นใกล้ๆจบเร็วเกินกลับมาหน่อยถอยใต้โอเค and then put in the ring and water test yes it's okay this is the pre-discharge echo. It's a patient. So I think that now there is a few papers about rheumatic MS repair. In my hospital, we do only the 20 cases of rheumatic metabolic repair treated by MIS. I do MS and replacement in 10 and repair in 19. During this time, we also do the metabolic repair with full stoma in 27 cases. The age is between 9 and 44 years. Mean age is 70 years old. Most of them are pure metabolic regurgitation, and 3 of them metabolic stenosis. No hospital mortality. This is another case, just a short video to show. It's a female, 34 years old, class 2 and normal status 2. Echo show the restrict posterior leaflet and prolapse anterior leaflet. Yeah. The valve is the restrict. So first I do the annular stitch. After that, I have to mobilize both anterior and posterior leaflet by cutting resect the secondary cord from both posterior and anterior leaflet. This is the posterior leaflet. And then move to the anterior leaflet. It still have a very thick secondary cord. We have to cut the thick secondary cord of the anterior leaflet. And then we use the water test. And we found some polyp of the A3 at the A3. So I used the artificial cord to support the polyp A3. A3. Then put in the ring. Yes, that's with the ring. And with water test. This is the post-op echo, really trace MR. And this is the patient. This is just a very short video for this another patient. This is only 13 years old, female. He has a heart failure. Function. This is the show of recongestion. After medical treatment, he should see a polyp P2 from the absent cord. This is my early case, so the exposure is not really good. You can see the P2 was retract and fail and absent cord. So we just put in the PTFE cord to support this P2. No,ไปเร็วๆให้เลื่อนให้เร็วขึ้นเดี๋ยวไปท้ายเดินหน้าเดินหน้าYes. Okay, stop. Yes. This is the pre-discharge echo. Show competent mitral valve. No MR. And this patient. This is the chest rate 2-year post-op. No medication, just the penicillin prophylaxis. So, in my conclusion, I think MS metabolic repair for rheumatic valve is feasible, but usually I use for simple lesion, simple repair. As a sternal spelling approach, MS metabolic repair for rheumatic valve may be appropriate and beneficial for young patients. However, the long-term outcome has to be determined. Thank you.
Thank you very much for your presentation. It's very difficult. It's excellent. So in Thailand, you all of cardiac surgeon, you move to classical standard full sternotomy to so-called minimally invasive, even in a so-called mitral repair or replacement. But you know, the so-called the mean age of the patient who required mitral valve surgery, and even in the rheumatic and degenerative, so young, I guess, here in Thailand. So the concomitant procedure, for example, bypass surgery, aortic surgery, so some concomitant surgery required in the aged patient sometimes. So in future, you have to appropriately change the surgical procedure, I guess. Is there any comment? Yes.
Dr. Somchai, I'd like to congratulate your excellent results, especially in young age group. My name is PC Zhang from Seoul, Korea. and I'd like to congratulate you on a nice presentation. I have just a simple question. You have some young patients with rheumatic mitral valve regurgitation, and what is your policy for prophylaxis of rheumatic disease? Do you give some prophylactic penicillin for up to what age? Can you?
Actually, I come from the rural area, which where the incidence of rheumatic valve is still high. We can in my area, the acute rheumatic fever is not uncommon. We still see the patient like this, and usually we get the penicillin prophylaxis for maybe 30 or 40 years, but some patients still develop. I think actually when develop acute rheumatic carditis, with just my MR, I think that's my MR. But when they grow up, MR beget MR, you know, MR beget MR. So penicillin prophylaxis can prevent the infection, but that cannot prevent the progression of the rheumatic, the MR when it occur. I think so.
Well, I have several patients with rheumatic mitral regurgitation, ages around the 40s and 50s, and long-term result was excellent with this kind of surgery. So I'd like to congratulate you again. Thank you.
Thank you very much. Any other question? By the way, in my experience, I didn't have a young rheumatic, but some congenital one or something required almost 20 years mitral or something. In the future, 20 years or 30 years, maybe require redo surgery, I guess.
Yes. So
Now, one repair doesn't last
yes.
for a rest of life.
Yes.
So it's very important to how to approach at first minimally invasive, a second one, maybe, a second one and minimally invasive, maybe okay, or sometimes change the first anatomy. Or it's very important to make a strategy, how to control the patient lifestyle, I guess so. So in rheumatic, I did have a rheumatic heart disease, and last, the 30 years ago, I published the so-called redo operation, the mitral valve surgery, and also 4 times, 5 times required if the tricuspid or another rheumatic valve disease progress or something. So it's very important to follow the long time. Yes.
That's really a cool idea. What is the recurrence rate and reoperation rate after repair? I'm not sure there's any information on that out there. That in my practice, certainly the reoperation rate went way down when I started using routine artificial cords. And my impression is with artificial cords, the majority of patients, vast majority, never have another problem. But that should be addressable in the STS database. We should be able to take the linkage between that and the Medicare database and look and see which patients end up having another operation over a 10-year period. I don't know that those data are available. Nice idea, though.
Thank you. Is there a comment? So patient whose age is very young, it's very important to follow a longer time, not 10 years, 20 years. At the time, almost 30 years or more. So is there any comment and question? So, Somchai, thank you very much for your excellent, challenging topics. So, now this session is closed.